Primary care is dying in America. Administrative costs are swallowing clinical dollars. And employer-based healthcare, which covers more than half of Americans, is broken in ways that most people can't see. So what does real transformation actually look like, and who's brave enough to build it? Hi, everyone. I'm David Williams, president of strategy consulting firm Health Business Group and host of the Health Biz podcast, where I interview top healthcare leaders about their lives and careers. My guest today is Dr. Zeev Neuwirth. He's a physician, healthcare executive, author of 2 acclaimed books on healthcare transformation. He's host of the award-winning podcast, Creating a New Healthcare, and he's now head of strategic partnerships at Rezilient Health. With over 30 years spanning frontline clinical practice, health system leadership, and a career dedicated to reimagining how care is structured and delivered, Zeev is one of the most original and outspoken voices in the industry. Zeev, welcome to the Health Biz podcast.
David, a pleasure to be here. Thank you for that generous introduction.
No, it's good. Sometimes when people tell them, they start with an introduction like that, I'm like, well, let's just end the podcast now because I don't know if I can live up to that. But in your case, I know that you can. So
that's fine.
So, you spent, say, 30 years inside healthcare, all variety of situations. And I'm wondering, when did you first realize that the system wasn't just imperfect like any system, but really fundamentally broken?
Yeah. So for me, I had a sort of an existential moment about a dozen years ago. I was in the hospital system, as an executive and, had already practiced for, close to 20 years as a primary care physician, and then was a sort of a manager, and then moved into sort of the executive mode, running a fairly large portion of a hospital system in terms of ambulatory care, outpatient care, population health. And I was looking at the numbers, and I realized actually the real moment came. I was in a meeting with a bunch of other doctors and what we used to call suits and white coats. And we were talking about access and how access was really poor. And I just sort of had this kind of just pause where, kind of out of body experience almost, where I was like, wait a minute. I remember the same exact conversation 5 years ago in this same office with a similar group of white coats and suits. And I sort of got a little kind of diaphoretic, got a little sweaty thinking about it. And then I thought, wait a minute. I remember the same exact conversation 10 years ago back in Boston with a different group of doctors and executives talking about the same problem with the same solutions that were going to go nowhere. And I started to think about, look at what we've done as a country. The cost of healthcare, astronomical, getting worse, much, much worse than it was, when I started. Access is no better to care. Convenience is no better. Back in 1999, 2000, I was in Boston with Don Berwick and the IHI, the Institute of Healthcare Improvement. And, the Crossing the Quality Chasm came out, and we were like all giddy, like, here we are, we've got the data and the digital and the EMR and population health, and we're going to cross that quality chasm and we're going to make healthcare in America great. 2000, that's 25 years ago, a quarter of a century later, we have not even begun to cross the quality chasm. And this is not opinion. This is data and this is facts. And when you talk to people who really understand it, I'll tell you on a very personal level, I trained at I did a master's at the Harvard School of Public Health, where I've subsequently taught. And, and when I talked to my professors, when I was there as a graduate student, I was already a physician, already an executive. I did a executive master's program there. And I would talk to the professors there, and they would tell me things like, when we go into the hospital, I don't leave my spouse alone. I literally won't leave their bedside because I know the data on hospital, mistakes and errors. I know the system. Again, so this is at a macro level, this is really tragic. At a micro level, at the human level, at the family level, this is just, it's unimaginable that a country this great, and by the way, I just want to be very clear, David, this is not a knock on at all criticism of the doctors, nurses, PAs, NPs, staff professionals, clinicians, all the administrators, all the folks in healthcare. And I've been in this game for now nearly 40 years. And I'll tell you something, I have just unbelievable admiration. And I mean that so sincerely. I mean, the people I meet in healthcare, they are hardworking, they are smart, they are expert, they are professional. I mean, I'm going to be honest with you. Everyone I meet in healthcare, I think, oh my God, they're so smart. I wish I was that smart. And they're so passionate and they want to do the right thing. And we have more money than, we're the third largest, if we were an economy, the third largest country in the world, our healthcare system, all that amazing input, and the outcome is miserable. And in part, it's because I think we've lost our way. The industry is growing by leaps and bounds. It's, there's more money in it that anyone could know what to do with. And yet the health of the country is declining. And again, when you compare lifespan and healthy lifespan, so the number of years you live healthy compared to every other country, we're healthy lifespan, we're 80th. We rank 80th in the world, 80th. And so I just, we have to. And so the question is, okay, I hear that, but the question is, so what can we do?
Yeah, so I would say,
right?
all right, well, hold on the answer for a second. So, you react to this by coming up with the answer and trying to implement that. I reacted to it by starting a cybersecurity company on the side, because at least we can show some achievements. But, you're exactly right. A course about going into the hospital. I wrote a blog post way back that said, going to the hospital, BYOMD, like you need to bring your own doctor. That when we go to the hospital in my family, I have a family member who's a physician, and we make sure that he comes or is at least on the phone. This happened just the other day. You actually need to do that. And it's sort of like, don't go to the hospital alone unless you're planning to die there. And it's not because we don't have enough resources or enough patients. I did actually have Don Berwick on as a guest here when he was running for governor of Massachusetts. I interviewed all 9 candidates for governor. And I remember one of the things he said about cost. This was at the time, by the way, of the new hepatitis C treatments that were coming on the market. And I said, how are we going to afford that? And he says, what we got to do is find a way to stop spending money on a bunch of stuff that's not worth anything so that we can make room for those that are. But I think we're still spending on both.
Yeah. And, I want to be clear. I don't want to, critique or criticize the hospital systems, because the hospitals do amazing things. I'm a huge fan of hospitals. I actually do think that we have to work with hospitals rather than disintermediate them and support them. I mean, they're just one manifestation, one piece of the puzzle. I mean, I could turn to outpatient medicine too. I mean, why is it that, 40, 50% of the country has hypertension? 80% of that is not controlled. I mean, what are we doing? Right. I mean, diabetes, the majority of it is not controlled. I mean, obesity. So it's not just the hospital. The hospital is just one piece of a larger system that, I would say is somewhat to, I think what you were getting at is a bit misguided. And I can dive into what I mean by that.
Sounds good. Well, I cut you off right when you said the answer is. I feel it's like one of those movies. It's like maybe there isn't an answer, but let's hear about your answer. And also, I'm interested why the focus on employer-based healthcare, whereas like often people say, well, the government is the one that's making all the policy. So I'm intrigued by that employer-based focus too.
So the solution is a high level one, because we could spend some time getting into some big ticket items and details, but and I'll give you a couple. But when you have tried something for 40, 50, 60 years and it's not working, and you keep on trying and trying, and you say, well, if I just throw more money at it, or if I throw more technology at it, or if I throw more science at it, you keep on trying that, and over again in different permutations. Now it's AI. Before that it was digital technology, and before that it was data, and before that it was the electronic medical record system. I mean, again, the value of being in this game for so long as I have, I've seen this story. I've seen this play this is like the 6th time. And, so the simple answer is do anything else but what you're doing. Do something different. I mean, it's basic wisdom. If what you've been doing is not working, don't do it better. Don't do it more. Do it differently. And so a very, very concrete example, I think, kind of a little bit of what you were going to is like, we spend 5% of healthcare dollars in this country on primary care. Okay. 5%. We know that most chronic disease, 80% of chronic disease, can be mitigated, reversed, radically reduced by preventive, proactive primary care. So why aren't we spending more money? Other countries spend 2 to 3 times that amount, relatively speaking, on primary care. Um, we've really denuded primary care in this country, and it's going away. As you said in the introduction, it's dying on the vine. When I talk to the experts around the country, primary care essentially is on life support right now. It's in the ICU and it's dying. And I'll tell you something, when that goes, uh, watch out. The system's going to implode because, relying on specialists. And again, I love specialists and I appreciate what they do. Some of my best friends are specialists. Important, critically important work, but we have to right size this system.
So let's talk about primary care. So I ran I was doing a panel discussion about primary care for a nonprofit that I volunteer for, and I was actually looking for people in primary care, and it's mostly like a couple of older people, and we found somebody that's a med student who was planning to go into primary care. And so I said, well, one way we're going to be able to get people to come to this event is I'll say, hey, the door prize is an appointment with a primary care physician, which is hard to get even in Boston, or especially in Boston. And then also the ground rule is don't tell this guy not to go into primary care because we may need some people to do it. But I mean, it's one thing to say we should be spending more on it, but it sounds like, it's in the ICU, it's dying on the vine. I mean, what's killing it, and why is that happening?
Well, primary care essentially has become a feeder for specialties and for the hospital. When, primary care providers are required to, forced to, incented to see a patient every 15 or 20 minutes, you barely could get, okay, you've got hypertension, diabetes, high cholesterol, whatever. I'm just going to write a script and give you a prescription and, out the door. Right. And so, primary care also, primary care is sort of like, it's kind of the garbage dump of healthcare. Everything is sent to primary care, right? The specialists don't want to deal with a lot of stuff. Now, again, I will tell you that a lot of my specialty friends do a lot of extra work, but primary care, you come home after a full day of seeing patients and you probably have 2 or 3 hours, right? This is documented in the literature, at least 2 or 3 hours of work just to take care of the work you did that day. And then you'd like to actually prepare for tomorrow to see those patients. So when they walk in, it's just like, nah, I'm looking at the note, trying to figure out who you are. I mean, essentially, and this has been sort of calculated and discussed in the literature, the medical literature, if you're a good primary care doctor, you probably are working 18 to 20 hours a day. That is obviously impossible for anyone. But I'll tell you, I know doctors for years who literally take vacations to do nothing else but catch up on their paperwork. This is insane. It's abusive. You talk about the burnout in primary care, which is over half the doctors are burnt out. They're not burnt out because of seeing patients. They're burnt out because they're not actually doing what they wanted to do, which was actually take care of people. Primary care is a relationship-based profession. If you're a surgeon, it's fine if you barely know your patient. It's fine. You make sure you're doing, this is the right patient, getting the right procedure. You make sure they're prepared for the surgery. But literally what you do, the patient is unconscious. They're knocked out, they're asleep. You can't do that with primary care. Primary care is a relationship-based thing. I think we've really lost sight of the fact that it's not transactional. If all it is transactional, it's like going to a machine and saying, I've got this and out comes a medication, that doesn't work. We know it doesn't work because we're doing it now. I mean, people don't trust doctors. They don't take the medications they're supposed to take. The doctors don't have the time to create those relationships. And so we're really shooting ourselves in the foot. This is the Ben Franklin thing, a stitch in time saves nine. I mean, we're really spending much more money on the downstream because we're not spending a few pennies upstream. And so we really have to right size that. And, what I'm doing now, you talked about direct primary care and direct to employer care. It kind of goes back to what I was saying before. We have to do something different.
So as you said, you and others have realized that this primary care thing just doesn't make any real sense what we're doing, and have not just thrown your hands up in the air and said there's nothing to do about it. Say, like, what should we do about it? And we do hear about these models. So what I've seen, in
Mhm.
my own
Mhm.
experience is I'll have a physician and then they'll say, this is insane. I'm just going to start a concierge practice. Now, of course, what that does for them is it gets rid of this problem that they could take vacation and maybe they could go to the beach and take a few days off as opposed to the paperwork and say, I see fewer patients, I make the same or more money, and I get to take care of them. It's more satisfying. Now, of course, from a population standpoint, if they go from a panel of 3,000 to 300, then they've
Right.
just thrown everybody else out there. So that is not a good systemic
No.
solution. And so things to me sound, and I want to hear about them, direct to employer care, direct primary care, that I think don't have that problem of just reducing capacity overall in the system. What are those models, and why are they promising?
Yeah, and you're right about concierge. It's the right idea in terms of I'm going to have a smaller number of patients. I'm going to charge them a lot of money so I can actually have a practice. I can sustain a practice financially, and I get the time to see my patients. And you can actually create a practice in concierge care, charging a couple to a few $100s per member per month. You can see 400, 500, 600 patients and really be like, their doctor. It's incredibly satisfying for the physician, incredibly satisfying for the patient. The problem is, to your point, first of all, how many people can afford to pay that? I can't, quite honestly. Most Americans, 99% of Americans cannot afford that kind of, concierge level care. So how do you create that sort of situation in an affordable way? And so one of the ways is sort of this direct contracting. And now it's being done. By the way, most people are not even aware how big direct contracting is in this country. At this point, 40% of large employers have been contracting directly. So they bypass the insurance company, which, by the way, a lot of money is in the middlemen. They cut out the middlemen. And they go either directly to a provider or a provider group or directly to a hospital. And this is happening. This groundswell is huge. Whether it's to surgical specialties, to hospitals, or to providers like primary care providers. So the idea is, you contract directly, you reduce the costs, and by contracting with a population. So let's say an employer has 1,000 or 2,000 or 5,000 or 20,000, you contract for that population, you become the provider. And again, with 20,000, obviously you're not going to have one provider. You'll have a team of providers, but you actually contract directly with them. You set up a payment model that allows that direct primary care to spend the time and build the relationships that are actually required for the outcomes you want, which are, essentially good health outcomes.
Got it. Now, let's talk about how technology comes into that, because you just mentioned a few things between data, EMR, because the personal health record for a while, and now we're up to AI. Now, it is the case that there's some role for
Mhm.
technology. It's clearly not a panacea. What
Mhm.
is your view on what technology can do and can't do, at this moment, or looking forward for a
Yeah.
transformation?
Yeah, and I just want to be clear. I think technology is critically important and absolutely necessary. Um, Technology, in my mind, is never the solution, but it is a profound enabler. And so, if we ever think it's the solution, I think we're just fooling ourselves. But it is a critical and necessary enabler. In fact, in the second book, I talked about technology and business model transformation are the two powerful enablers. And I think if you're not transforming your business model and you're not using state of the art technology, you're not going to be successful in the future of healthcare, no matter who you are. So, having said that, a very concrete example is now the ability to have AI scribes. So before, the physician, we all know this. I think anyone who's ever seen a doctor or anyone who's in clinical care knows this. You walk into the room, the provider is actually facing the screen. They've got the keyboard, their fingers are planted on the keyboard, as opposed to looking at you and talking with you and touching you, because they have to input all the data into the electronic medical record. Which, if you think about it, think about this. You have a person who's not only gone to high school and college, but they've gone to medical school and then they've done a residency on top of that. Post college training, anywhere from 3 to 10 years after college. And now you have them spending 40% of their time doing data entry. Seriously. I mean, that's what you're paying your incredibly sophisticated and experienced and costly physicians and others to do. It's absolutely ridiculous. Now with AI scribes, literally the provider doesn't have to do any of that. The scribe will automatically be putting it in fact, probably better than the physician in putting that data in, bringing in other data to actually inform the physician, prepare the physician for the visit, remind the physician, of here's, literally saying, here's the possibility. The patient just said a whole bunch of things. It could be A, B, C, or D. And I think we should recommend these tests. I mean, that kind of enablement. And, a lot of doctors worry, oh my God, AI is stealing my business. AI is not stealing your business. AI is going to empower you to be better at what you do and actually be able to do it for more people. So, so that's one concrete example. It's actually happening now. It's actually, 5 years ago or even 3 years ago, the idea of an AI scribe was sort of like, wow, this is new, et cetera. Now it's table stakes. If you're not doing this, you're behind, right? And that happened literally in 3 years.
Let's talk a little bit about value-based care, because that's been kind of the mantra. We just pay people for the hours and work that's done, and we should pay for performance, and then we can tie in the whole medical loss ratio to the physician is doing. And I'm thinking about, like, in a way, yeah, that makes sense, but also in other areas of the economy, like when I go to the gas station, I pay, per gallon. I pay a lot of things per hour if someone's working on, if I have a hire handyman for my house or even a lawyer. So why in healthcare is value-based care getting so much attention, and does it work?
Yeah, it's a really, really great question. And I think a little complicated. I do think, if you look at what's happening now with some of the payment, what's been happening for the past 10 years since, since the Obama Act and Obamacare, with the Center for Medicaid and Medicare Innovation Center, CMMI, they've been testing out a lot of payment models. I think we're now, surprisingly in some ways, with this administration, we're actually seeing some pretty really, really good payment models, largely focused on what they call outcomes aligned payment, OAP. And for instance, there's this AXIS model, advanced chronic care, with sustainable, scalable solutions. And they're basically paying now for outcomes. So for instance, like around high blood pressure, if you reach a certain level, and I forget, it's like a 140 over 80, you get a certain amount of money. But if you actually get your population down to appropriate, 120 or 80, you get more money. So it's now like, we'll pay you for outcomes. And I think that direction. Another is the Teams model, looking at surgical bundles and so outcomes as well. So I think this notion of so-called value-based care, which can mean a lot of different things, I think I would start to agree with where I see the language moving more about outcomes aligned payment. And having said that, another thing which I don't think is recognized enough, and I think this is why we were talking about direct contracting. I think we're misguided in terms of the whole insurance model. Primary care, basic primary care, is not an insurable thing. It shouldn't be insured, right? I mean, insurance was built. The whole idea of insurance was, if something has a very, very small likelihood of happening, less than 5%, sort of life insurance, right? I mean, hopefully your chance of dying is rare, right? House insurance, hopefully your chance of being struck by lightning or something happen is rare. It's less than 5%. There, mathematically, it makes sense to insure it because it's rarely going to happen. You would not insure, let's say, do you have gasoline insurance?
I was going to say, right? Like, I'm not going to insure for my oil change or my monthly electric bill, but if my house catches on fire or I total my car, different matter.
Right. Why would you insure primary care? You need primary care. It's not like, do I need it once in a while? No, you do want preventive, proactive primary care. We know when a population, a community, an employer has primary care, people's health improves. and the cost of care goes down. We know that. It's been demonstrated over and over again for decades. So take it out of the insurance pool, pay for primary care like you pay for gasoline, like you pay for, like you're saying, your heating bills. You know you're going to use it in the winter. You don't insure against heating. You just pay it on a monthly basis. And it's the same for primary care. Pay that. And, the truth is, as I said before, it'll pay dividends in terms of reducing the need for specialists, emergency room visits, procedures down the road. And by the way, it doesn't take that long to actually see that return.
Got it. All right, so let's expand the discussion a little bit beyond healthcare and talk about health, and also beyond, when we talk about technology, beyond information technology to maybe some other types, including pharmaceutical. So, we mentioned up front how we spend a ton on healthcare, and outcomes are not that good. People don't live that long, et cetera. And that's all true. It doesn't necessarily follow that it's the healthcare system that's causing that. And there's some broader, kind of health and lifestyle pieces that come out. And the goal is health. It's not, my goal is health, not better health care. And then on the technology side, I think where this comes in, a lot of people see it is with the GLP-1s. So it's, that's a type of technology that you can use and have a big impact. So how do you think about health versus healthcare and technology broadly?
Yeah, that's a really, really good question. In fact, I was just talking to someone about the difference between healthcare and health. So, I think our healthcare system is largely a reactive system. People call it the sick care system, which, by the way, I don't think that's a criticism. I'm super grateful we have a great sick care system. I have family members who have it saved their lives, and because of the expertise and the technology in the hospitals, and I'm beyond grateful forever for the sick care system. So that's not a bad thing. But what the sick care system, or so-called our healthcare system, is not really good at is health, making people healthy. And we know, again, most of chronic disease, 80% of it, 90% of it is around nutrition and lifestyle changes. It could be greatly reduced through that. So the question is, what can we do to improve our health? And not just, improve our illnesses and diseases, but actually prevent them or mitigate them. And so I do think that the healthcare system can play a role in that. So, for example, we have primary care physicians and other physicians. You don't necessarily have to be a primary care physician, but generally speaking, it's primary care providers who are boarded in lifestyle medicine. There's an American College of Lifestyle Medicine. It is an evidence-based approach. You get a board certification for it. And these providers are trained in nutrition and physical activity and stress and sleep, in the factors that really, and they know how to coach people. And on top of that, to your point about cost and getting to a population, you have to learn how to do this as a team, right? So you have a team doing this so that the doctor is not doing everything. The doctor is doing what they do, but then you have a nutritionist and behavioral therapist, and you have health coaches, et cetera, physical therapists. So it is really a team-based sport. And if I think we convert, bring in lifestyle medicine, convert it to that sport, I think the healthcare system can play a role. And then when you ask about technology, I think the notion of even some of the wearables using feedback to say, okay, Zev, how is your sleep? We know that sleep is huge, bigger than anything you might imagine. People are taking testosterone. You don't need to take testosterone. Get 8 hours of sleep a night. That's when your testosterone is made. By the way, it affects your weight. It affects your mental health. It actually is a prevention in terms of dementia. So, but I don't know how I sleep until I actually put a device on and it tells me, oh, you're getting this kind of sleep or not. And then you can work on it. So I think the marriage of bringing this sort of lifestyle medicine approach combined with a team-based approach to lower the cost and get the real experts to help the providers, the physicians, and NPs and PAs, and couple that with technology. GLP-1s and peptides are a whole other story, which I have some concerns about.
Yeah.
And I know I'm not the only one. It's in certain cases, they're miracle drugs. Let's be clear, right? If you have diabetes or heart disease, it is the literature is pretty clear. I worry about the way it's being used now. It's being used as a substitute for appropriate nutrition and appropriate exercise. And the problem with that is that it does have side effects. And the literature right now, as far as I can tell, is saying that most people will be off of it within a year or two. And so you've taken tremendous costs. Someone's paying a lot for these medications. They have side effects, and they cause sarcopenia, loss of muscle mass. So you find yourself 2 years down the road, having paid a lot of money. Now you've given up the medication, you've gained the weight back, and you have less muscle than you had before, and you've put yourself at risk, and you haven't changed your lifestyle. And so I worry without that preventive primary care. So I'm not against GLP-1s or peptides. I'm just saying they need to be coupled with primary care, preventive, proactive primary care.
Sounds good. It sounds like that when you hear about like these lottery winners, who then end up destitute, that plus the GLP-1s and in 2 years are going to be in much worse shape than when they started. Well, let's end it there. So that's it for another episode of the Health Biz Podcast. My guest has been Dr. Zeev Neuwirth. He's a physician, author, and head of strategic partnerships at Rezilient Health. If you like what you heard, please subscribe on your favorite podcast platform. And Zeev, thank you so much for joining me today.
Thank you, David.